Okay, good evening, everybody. Welcome to the fifth ski webinar. And today we have a very interesting and a hot topic, which is on the ACL injuries and ACL reconstruction. And we have none other than Dr. Sachin Tapasvi, who's going to take us through this. He has rich experience in treating ACL patients. And today he's going to bring out through his 4 to 5 cases on, what are the current trends, what are the controversies going on, and how does one manage ACL injuries. So we have a very rich panel again. We have Bhushan, we have Dinsha Pardiwala, we have Kanchan Bhattacharya, Mukesh Ladda, Raju Ishwaran, Jacob Verghese, Clement Joseph from Chennai, and we'll have Vikas Khanduja and Vikas Kapoor tuning in soon. So over to Sachin Tapasvi to take over this roundtable webinar presented to you by SKI.
Okay, thank you, Parag, and welcome everybody to this webinar. Essentially, looking at ACL injuries. We have a rich panel here with tons of experience. I mean, if we count the number of cases between these 8 to 10 gentlemen, I think easily you'll see more than we'll see an experience of over 10,000 ACLs treated by this whole panel. So essentially, we'll be going ahead and what is this now?
Yeah, sharing.
We'll be looking at some basic cases, and we'd like to have this interactive for all of those who are participating through the YouTube channel. You have a YouTube link box there in front of you, and please feel free to put in and share your questions. Of course, your questions can be sent by WhatsApp to to Ashok Sham and Dr. Parag as well. And we start off with the first case. So this is a 32-year-old male. He had a twisting injury during soccer on artificial turf. So nowadays, I see a lot of these patients coming in with injuries with soccer that they play on weekends on artificial turf. And probably they're not using the right shoes or whatever it is. These weekend warriors, they come in with these torn ACLs. So these are essentially, he had a non-contact injury. He's now 3 weeks post-injury. He has a range of motion from 2 to 135 degrees. On clinical exam, he has a grade 2 Lachman. He has a grade 1 pivot shift. And on detailed questioning, he wishes to stay active and definitely wants to go ahead and pursue his career of playing sport over the weekend. So we have this MRI scan picture here for you, which shows that this is a oblique T2 sag image, which shows the entirety of the ACL. And one can see that this ACL is injured at its proximal insertion. So the question here that we want to ask the panel is, what would be your preferred treatment in this particular individual? Would you definitely want to just modify his activities, do non-surgical treatment? Do you want him to be subjected to an ACL repair, or will you want him to have a remnant preservation ACL, or do you want him to have essentially what, as we would say, a conventional ACL reconstruction, where you will not pay too much of attention to his whatever is remnant or his ACL bulk, and go ahead and do a conventional ACL with whatever graft source is what we prefer. So my first respondent on this will
Sorry, lost you.
Even I can't hear.
Sachin, the audio is gone. Ashok?
I think Sachin sir's internet is unstable a bit today.
Fine. Okay, sorry. Okay, Mukesh,
now we can hear you.
Bhushan, Bhushan, can you take this question for us?
Sure. So, a 32-year-old male with unstable knee. So, does he complain of instability? Has he undergone some?
He's undergone rehab. He's now 3 weeks post-rehab. And 3 weeks post-rehab, he comes to you and says that you've done a clinical exam. Of course, he's not gone out and played as yet, but he says that he wants to stay active and wants to keep on doing proper exercises and gym and whatnot over the weekend. So what will be
I
your
agree.
choice of treatment for
So
this?
he's someone who's not going to modify his activities, and I think he's going to fall into a surgical treatment group. Of course, there are about 5 to 10% patients who can still manage without the ACL reconstruction. But let's looking at this patient scenario and MRI, he's quite a juicy case. 3 weeks post-op for a ACL repair. We are not beyond 6 weeks. There is a nice chunky remnant still present, and it's avulsed from the femoral attachment. If there are no concurrent meniscal injuries,
Isolated ACL.
Isolated. So it's a very good case for ACL repair. You of course have the option of a remnant preserving ACL reconstruction as your backup. If you do your arthroscopy and feel that the remnant is not a good looking one, or if it's shredded completely, I would rather go and try an ACL repair. I'll
So
tell the
your
patient
first
there's a
preference is a
70%
repair.
chance of healing.
Your
I'll
first
say
preference is a
70%
repair.
chance of healing.
Kanchanda,
Yes, I do.
what's your preference for this particular patient?
Remnant preservation. Not very happy with ACL repair in my hands.
Okay, Jacob, your take on this?
I would also think if I can repair it, I'll make the decision on table. If I can't, I'll do a remnant preserving ACL.
Raju, what's your take on this particular patient, and what's your choice of treatment?
It will be a remnant preservation ACL reconstruction, mainly because ACL repair, even though it looks like a Sherman type 1 stump, it's the long-term results are not firmly established for me to think of it in this particular individual.
So nobody will want to decide or take the option of doing activity modification per se?
I would.
I will.
Okay.
Vikas Kanduja here.
Yes, Vikas, very good morning or good day for you actually, yes. It's
Good afternoon.
Good afternoon actually, correct. So Vikas,
Yeah.
you would like to go ahead and help him with non-surgical treatment.
Yeah, absolutely.
And
So
what's-
I would
Yeah.
get him to the gym first, and we would actually measure his quad strength.
Yeah.
And I would definitely give him 12 weeks of appropriate rehab, and make sure that his quad strength actually comes up. Measure
Okay.
his hamstrings as well,
Yeah.
and do an objective measurement of both, and then 12 weeks later, see how we are doing, comparison with the other side as well.
So do you feel that by waiting for 12 weeks, you may have lost the chance to preserve his remnant or do a repair?
I'm not in favor of a repair because I do not think we've got long-term data, especially for this kind of an individual on repair.
Yes.
And in terms of remnant, if I have to go for it, I would definitely go for a remnant preservation ACL, and that even in 12 weeks, that would be okay.
So the basic argument being is that somewhere around the 4 or somewhere around the 6 to 8 week mark, the process of ligamentization proceeds in such a way that the ACL stump starts contracting. So if you want to really preserve a lot of the remnant, then you should be in there before 8 weeks. That's the reason why I asked this question to you.
Yeah, but Sachin, what's the evidence of that? There are 2 papers, okay, and we base all our ethos of management just based on those 2 papers, just because they have said that. How many times have you gone in and actually noticed that even at the 12-week mark, you've still got enough of a remnant to actually work and play around with?
Fine. So we'll come to the remnant part later on. So you for one are going to say that you are going to offer him non-surgical treatment. What is your endpoint of non-surgical treatment?
The endpoint at 12 weeks, if he is still unstable and if still got a pivot, I definitely at 12 weeks get him to start seeing and playing a game or 2. If he's still feeling unstable and there's failure of conservative management, then I would consider surgical intervention.
So subjective and objective both, or only subjective?
No, subjective and objective both. Objective based on how much of muscle strength he's gained, and the KTs, and subjectively if he's getting a feeling of instability whilst playing.
So what is your cutoff point on KT?
Depends on what you start off with.
Okay. So do you take a side-to-side difference or day 1 reading and sort of 3-month reading?
Both.
Okay. So anybody sorry?
Yeah, go ahead. Because if the patient has got an element of hypermobility,
Yeah.
then side-to-side difference alone will not help.
Okay. Anyone else on the panel uses KT for decision making?
No.
No, no one on the panel is using KT as well.
Oh.
Right. So I think a lot of us do not. Probably Dinshaw may have KT at his setup, and Arumugam definitely has one. But at least I don't have KT, or I don't have instrumented testing in my clinical setup per se. So fine. So anybody else who just wants to do a conventional ACL reconstruction for him?
Yeah, so my take would be I would do a conventional ACL reconstruction, but at the time of doing it, whatever remnant I can preserve, I will preserve it.
Yes.
Definitely a ACL repair is not on my list.
Okay.
First of all, I have not done any yet, and I think it's quite a technically challenging procedure to do it. So when you have something which is stood the test of time, I would do that. And while doing a conventional ACL, whatever remnant comes in my way while making the tunnels, that goes. Otherwise, I preserve whatever I can. So that would be my approach, Sachin.
Okay, fine. So I actually went the Bhushan way for him. And since this was a type 1 Sherman type of an injury, where you have the ACL that comes off from its femoral insertion, after having had a detailed conversation and discussion with the patient about what his desires are, what sort of sport he wants to play, is he willing to give me those couple of months of rehab, etc. I chose to do ACL repair for this particular individual. The technique is sort of well written up. We also wrote it up 2 years ago. And essentially, it consists of passing at least 4 or 5 sort of throws of strong suture through the substance of the ACL, and then repairing it back to its insertion point with the help of knotless anchors or adjustable loops. Here we've also added internal brace, so as to say, to protect this repair, which is definitely a bit controversial. The reason why we've added the internal brace is because of these couple of publications which did not have such a huge follow-up, but they did show that when you add an internal brace, then your ACL repair, you can achieve better range of motion and better function with it. Another couple of papers that looked at the use of ACL repair with an internal brace, a systematic review.
Sachin, we are losing you. Yeah, Sachin, Ashok.
Yes,
Yeah.
I think Sachin sir's internet.
Yeah. Now,
Sorry?
Sachin, now
Again,
we
I'm
can hear you. We lost you for 30 seconds.
Go back.
Okay. So why is my net creating problems today? Anyways, so systematic review again of 25 studies does show that if you have internal brace that is put on, then the repair strength is improved. Of course, these are preclinical studies which we are looking at, and also another comparative study from the HSS group showing that if you add an internal brace along with an ACL repair, then your repair is less likely to fail. And this is what the KSST paper sort of shows. It takes up patients who have an acute ACL tear, who have a BMI of less than 28, and of course, no hyperlaxity. So you take all the acute ACL tears within the first 3 weeks. If they are a type 1 tear, then you want to see if you have sufficient length and sufficient quality of your ACL stump. And if you satisfy these criteria, then if you go ahead and do a repair, then of course you will find that almost about 88% of all type 1 tears you will be able to repair, and almost about 20% of all your ACL tears will be a type 1 tear, which is what this paper shows us. So ACL reconstruction is still the gold standard. The role of ACL repair probably is for that particular individual who is between the age group of 25 to 35, who has a BMI of less than 26 to 28, who is within the first 4 weeks of the injury, preferably you should not have any meniscal damage, and it should be ideally a type 1 or maybe some selected type 2 tears. The role of internal brace is essentially probably to strengthen your repair, but definitely needs more clinical data. And this is probably what I can share today on the role of the internal brace. Of course, we don't have long-term studies, so Vikas's comment on we don't have enough data is justified. But whatever short-term data that we have, looking at 3 years, 4 years follow-up of this technique does show that the results are definitely encouraging. Anyone on the panel wants to make any comments on this particular aspect?
Dr. Sachin, I just want to point out that the February 2020 issue of Arthroscopy has a very nice review article on ACL repairs with an editorial commentary by Lars Engebretsen. And the summary of that editorial commentary, Lars has clearly stated that as of now, the data doesn't support the routine use of ACL repair by most of the ACL surgeons. It is only meant to be used when you are attempting to do a multi-center study. So he has clearly put out the recommendation that unless the procedure is subjected, because this was in response to a paper in which ACL repair group said that patients actually felt better than ACL reconstruction. So this was on a patient-based questionnaire of one side which was reconstructed and the other side which was repaired. And this group went on to claim, I think it was De Felice's group, if my memory serves me right. And the editorial commentary to that clearly stated that it is not a good instrument to check the validity of this surgery, and more rigorous tests are needed. So these are the February 2020 arthroscopy paper recommendations.
So most of the data that you have. Yes, yeah, go ahead. Yes,
I've got a quick comment as well.
Yes, because yes.
I would completely concur with Raju and what was said in that editorial. And especially in forums like this, I think we need to be extremely careful about what we are popularizing, because people consider all of you as ACL gods in India. And if you start popularizing ACL repair for this patient cohort, then a junior surgeon is actually wanting to do the same when there is not a lot of data out there on it. And it's a technically challenging procedure. The other biggest issue is that we do not have a control group. Nobody's actually looked at the same patient cohort having an ACL reconstruction versus in one arm versus ACL repair in the other arm. So unless and until we've got a control group, or in fact even managed conservatively, then it becomes very difficult to support this. That's the only issue.
Yeah, point well taken, Vikas. Definitely, I think if this whole group can come together and look upon this as definitely a ski multicentric trial, I think it will be really a nice way to take things ahead. Of course, there is no doubt that this is a very small sort of selective group of patients that can actually have this surgical technique. This is not for all the patients that come your way, but definitely those select group of patients may be subjected to this particular technique, which essentially helps in you not being able to not needing to harvest graft, etc. Question to Bhushan Sabnis here is that I'm sure that he's worked at a couple of centers in the UK where a lot of these repairs have been done. What has been your experience looking at follow-ups, Bhushan, in those particular patient groups?
So now we are looking at 5-year follow-ups. I think 18 is written a paper already. It's not been accepted yet. And we are seeing almost 80% success rate at 5 years, which is a good thing. But one important thing which I want to share is that it seems to be working quite well in kids as well. So internal bracing with ACL repair has been done. Some people will laugh at this, but even in the younger age of 7 when I was there. So we have seen good results for kids as well. And unlike an ACL reconstruction where the tunnel keeps on lengthening, or your implants ultimately end up sitting in the diaphysis, in this group, if you are not violating the fascial plate, you actually get a natural ACL once it's healed. So you lose all the signs of any ACL repair done in future. There are a couple of cases where a relook arthroscopy was done, and it indeed seems quite good.
So Bhushan, that's fine, but what I feel, what Vikas Khanduja is saying, what is the consensus statement we should
No, so
make at this point of time
no, this is
to
a
all
controversial.
the viewers?
This is a controversial issue just now.
Correct.
What I think we as a group should say is that this is for someone who has a very good experience of ACL reconstructions and not for a novice, because the patient selection is very important. The length, if it's not sufficient, can land you in trouble, and you will get suboptimal fixation, and also you'll be unnecessarily putting up implants inside the knee.
Correct.
So I think it's to be done.
has been
Yeah,
put up in this slide very well by Sachin,
yeah,
that ACL instruction still remains to be the gold standard.
I
So,
think so. I think
but
so. I
we'll
agree.
see as time goes. Dinsha, I would be happy to hear what is your take on ACL repairs in patients coming to you less than 3 weeks.
So the only time I do an ACL repair is if there's a bony avulsion. I've seen a few of these bony avulsions from the femur. Yeah. So it comes off with a small chip of bone. And I think that those are the good patients that I would do a repair for. But otherwise, the standard, type 1 avulsions, I don't do repair. I do a remnant preservation ACL reconstruction. So that means I preserve the entire stump, and take my graft. So it won't be a synthetic internal brace. It would be a biological internal brace. That's your ACL reconstruction. You just need to make sure that your graft is not a 9 or a 9.5. It needs to be 8 or 7.5, so that you're not disrupting the tibial attachment. And then true ACL reconstruction, there have been times when I've used the remnant and the remnant just pulls up and stretches. Sometimes I've used an anchor to bring the remnant back, and sometimes I've sutured the remnant back to the old ACL so that doesn't flap and cause
That might be a good thing where you're getting probably the best of both.
Yes.
So Sachin, there are some questions, Sachin.
Trying to be safe on both sides.
So one was there was a few questions on ALL, because are you going to take that up at a later case?
Yeah, I think we'll discuss that slightly later when we come to the third
that
case.
was one question. And the second question was, is if a patient who comes with a ACL tear,
yes,
and is only the pivot shift an indication for doing an ACL reconstruction?
So I think that's a great question.
Yeah.
So as you see here, if you look at the clinical examination of an ACL, the drawer test essentially does not carry much meaning in when you're trying to clinically examine an ACL. Your whole clinical examination is based on two tests. One is the Latchman, the other is the pivot shift. Pivot shift is very difficult to do when the patient is acute. It is not very reliable if you do not have a relaxed patient in your clinic. A pivot shift is best examined or best evaluated when the patient is asleep under anesthesia. So for me, pivot shift, if there is a demonstrable pivot in your clinic while you're examining your patient, then definitely I think that this represents a grossly unstable knee. The pivot shift has two components to it. You have velocity, you have translation, and based on the amount of glide or the amount of shift and the speed of the shift, you can grade your pivot shift into either a type 1, 2, 3. Either one, there is no pivot, there is a simple glide, there is a shift, or there is an explosive pivot, is what you will grade it. So I think that would be the answer to that question.
Yeah. Another quick question is that when would you do an MRI after a knee injury? Is it immediately, or is it later, taking into fact that it's not a multi-ligament injury? So what is the ideal time for doing an MRI in an
So this again becomes a bit of a controversial issue. The reason being is that you should learn to see what you want to see in that MRI scan. So an MRI scan is going to show up a lot of signals. So if you do an MRI scan on day 0, if you do it at 1 week, if you do it at 2 weeks, if you do it at 3 weeks, it is going to show up different signals. So essentially you're doing an MRI scan to sort of corroborate your clinical diagnosis. So if you are if you clinically you have sort of found out that there's an ACL tear, so and I'm pretty confident of my diagnosis, then the reason why I would do an MRI scan is to pick up any meniscus tears or to pick up any chondral injuries, if at all. So meniscus tears will be seen in MRIs which are up as early as 3 days, 4 days old. Chondral injuries actually with the presence of hemarthrosis, which acts like an indirect contrast medium, can be seen better when there is fluid inside the joint. So for me, an MRI scan is somewhere around the 5th or the 6th day is the best time to see it. Of course, you will see so many other structures that are bruised. You will see an injury to the ligaments on the lateral side, and very often these get reported as a lateral collateral ligament tear or something of that sort. But essentially, your clinical diagnosis is going to tell you what type of injury pattern he has got. So anyone has got anything extra to add on what I've just said as regards the MRI scan?
No, we agree.
Okay, perfect.
One last quick question on this, or
Yes.
I don't know whether you're going to cover it later. There is a question on what is the management in a partial tear or a single bundle tear of the ACL.
So perfect. So we'll discuss this question on this particular example
okay,
here.
perfect. Yeah.
So this is a 26-year-old female. She has an injury. She's 5 weeks post-injury. She's got, this was sustained as a result of a fall from a two-wheeler. So at the end of 5 weeks, she's had a decent rehab, and she's got a range from 0 to 130 degrees. She has a grade 2 Lachman. Her pivot shift is grade 1 plus, so maybe a grade 1 plus to a grade 2, and she wishes to stay active. She's got an isolated ACL tear. She does not have any associated meniscus injuries. So Dinsha, I would like you to take up this case and discuss with us what you would like to do. Essentially, what we're looking at here is that on her MRI scan, one can see that if you look at her coronal and her sagittal, there is some portion of the stump that is behind. Her Lachman is about grade 2, it is not grade 3. She's got a gentle shift or a gentle glide. So Dinsha, let's have your view on this.
Okay, so the way I see these patients is at 5 weeks, she's come to me, she's got symptoms. I'm going to really base all of my decisions on that clinical evaluation.
So Dinsha, she's seen you at around 2 weeks. You've put her on a rehab program, and now she's come to you for her second or third follow-up with 3 weeks of physical therapy. So now is your decision making that has to come.
Absolutely. Yeah. So we know that a very small number of ACLs will stabilize and will heal. If they do so, usually by the 4th week, you'll feel that they're much more stable. Since this patient now at 5 weeks is still showing me a grade 2 Lachman, I know that she is unstable. The decision taking is going to be based entirely on what her activity profile is likely to be in the future. If she's 26, in all probability, she's still going to want to dance. She's going to, run, jump, etc. So for me, I would be explaining to her that probably the safest thing to do is go ahead with a surgical procedure, which is a reconstruction. If, on the other hand, she told me that, look, I'm not that active, then I would give her a trial of non-operative treatment. But like what Vikas mentioned in the previous cases, he'd let the athlete go back, try out a game or two of football. I normally don't recommend that. I get really scared of these patients going in early, and then coming back with a meniscus tear, which will complicate the issue further. So based on her expectations, she wants a perfectly normal knee. Right now, she's unstable. I'd offer her an arthroscopy. In the arthroscopy, I'm in all probability going to do an ACL reconstruction. Whatever remnant is there, I'm going to preserve it and I'm going to preserve it, if necessary, suture it or anchor it back.
Okay, any difference of opinion amongst the panel? Clement?
Yeah, I agree with that. The patient is very young. I wouldn't risk trying to put her back into sports and coming back with a meniscal tear. I concur with what Dinsha said. Okay.
So essentially, this is, if you see her MRI scans, you can see that she has there is significant amount of ACL tissue that is still left behind. And this was essentially to bring out the so-called partial ACL tears, so as to see. So essentially, you have got two different types of partial tears, if I can say so. The first is the classic single bundle tear, which has been, which is in the lower image, which you have. This is the type of tear in which essentially one bundle is intact and the other bundle selectively tears, or you have the other type in which more than 50% of the fibers are intact and essentially only some portion of the fibers have got peeled off. The third type, which can sometimes mimic a partial tear, is what is called as lambda healing. So lambda is for the benefit of the other attendees. Lambda is a Greek symbol, and essentially what happens is that the roof of the lambda is the intercondylar notch, the intact PCL is the other limb, and the torn ACL goes and sticks to the PCL, and this is what gives rise to lambda healing, which is essentially what happens in these particular individuals. As Dinshaw has rightly pointed out, whenever you see a stump or whenever the MRI scan does show that these patients have a significant amount of stump that is there, I go ahead and scope these patients first to decide whether I'm going to be doing remnant preservation and how much of remnant can I preserve, and then only I will go and harvest the graft. So very frequently in these patients, I would only harvest the semity. I will not harvest the gracilis, and I will do either a tripling or a quadrupling of the semity to get a graft which is around 7.5 to 8 millimeters in diameter. And if you preserve the remnant, a lot of papers have shown that it has got better proprioception, better rotational stability, and better function. Dinshaw has his own way of doing it. So in this particular patient here, you try and preserve all that remnant, then go ahead and drill the tunnel. I prefer to come into the 15 blade and make an incision on the tibial side, take a medicine ball scissor, open it up, and also pass the scissor underneath the ACL, and then come in with my tip aiming device to the center of the tibial footprint. You don't want to see the whole sort of drill come through and through. You want to just see that stump dance, and you want to go ahead and put your scope in the tibial tunnel to see that you've completed it. Later on, you sort of have this retrieving suture that is pulled out in 2 steps, and then you pass this graft underneath this large thick stump that you have. You can see that the stump is still vascular. There is a blush of vascularity there, and I just prefer to close up the whole stump with the help of an absorbable vicryl suture so that everything stays down. And at the end of the procedure, you don't allow for a cyclops lesion, and your native ACL stump is preserving the graft that lies from underneath, and this allows for the so-called remnant preservation ACL. Anyone from the panel have a different trick to do this? I'll ask the rest of the panel first, and then Dinshaw, I'll speak to you because you have a totally another different way of treating these remnants. So anybody have any separate tricks?
Sachin, can I come in?
Yes, please.
Yeah, I do a similar to what Dinshaw is telling.
Yes.
So you're closing with vicryl, because sometimes when you leave the remnant alone, sometimes it can fall back and theoretically and can produce some locking. So what I do is I use the scorpion device to take multiple passes with the number 2 zero fiber wire, and I take the zero fiber wire into the femoral tunnel, and after I do the tightening of the locking device tightrope, so the 2 non-sliding white strands are there. I usually tie one of the white strands with the number 2 sutures, which are taken through the ACL stump. So the ACL stump is actually taken into the as close as possible to the femoral tunnel, and also you prevent the stump from falling back and producing a locking. So this is my variation.
Good. Anybody else have any different techniques of dealing with the remnant?
Sachin, there's one question which has come in, which is actually more for the repair. This is from Dr. Pankaj Valecha.
Yes.
What he's saying is that how do we know that the length of the ACL which is available is sufficient? Because Bhushan made a point that the length of the ACL ligament has to be sufficient to attempt a repair. So
okay, this is for the repair.
For the repair part, I'm just asking it right now.
Okay, so yeah, so I think for the repair, the first thing is that you need to have a good MRI evaluation whether your patient is amenable for a repair, and for that the use of an oblique sagittal plane imaging will show you whether this is a type 1 or a type 2 tear, and that is my first indicator. The second indicator which I will use is to see if at the time of surgery, if the stump is retracted and when I put in my first suture, it cannot be effectively reduced, then that becomes my second intra-op check control. And with these two techniques, I will sort of decide if the ACL is of sufficient length. And when I pull on the sutures, if the sutures are ripping out, that means that the tissue quality is also not sufficient, and then I will abandon it. So one is a pre-op check and the second is another intra-op check.
Just a quick follow-up to this question. What is the difference in rehab when you do a repair versus a reconstruction? This is asked by Dr. Parvez.
So Dr. Parvez, if I do a repair alone without some form of internal brace, then I will keep them in full extension for about 2 weeks and then start moving them. And you tend to get these knees to be a bit stiff. So to counteract that effect, that is why we started using an internal brace. And when we use an internal brace, you can get them to wet bear on the next day and you can get them to start moving on the same day itself.
Great, thank you.
Yes, Dinshaw, and then Mukesh.
I think another good tip is to, when you're doing that arthroscopy for a repair, look for the femoral stump. Make sure it's a true type 1. So if you see a femoral stump out there, then you know that that's not a true type 1. You shouldn't really see too much tissue on the femoral side. Everything should be as a tibial stump. So if you see a big stump on the femur, you know that's probably a type 2 and not a 1. And those are the patients that you probably would not like to repair, because those are the ones that don't, at least with the few papers reported, don't do as well as the type 1s.
Yeah, that's a good point. Mukesh, you wanted to make a point?
Regarding remnant preserving, sometimes I ask my assistant to retract the stump with the help of a probe, so that while drilling, inadvertently, if sometimes drill goes in, they should not damage the mid substance.
Yeah, that is definitely a good trick to use. Another way to protect your remnant is to get in something like a half pipe, or with some commercially available meniscus repair devices. You have this tissue protector. So many times I would place that tissue protector, if required, to a third portal to try and protect that remnant. So that's again a good surgical tip or point. Dinshaw, you want to make any comments on remnant preservation before we move on to the third case?
I think that covered it beautifully.
Okay. So if there are no further questions, Parag, any questions?
No, that's fine at the moment.
Okay, fine. So good. So we are almost now 35 minutes into this webinar. So I'll come to the third case now. So this is, I think, going to be a slightly challenging one. So now we have a 41-year-old male who is a police officer. He had a hockey injury in 2009. So now he's about 11 years following his knee injury. This was a non-contact injury. He got better, he tried to play again, and he again started getting discomfort. So he's given up the sport and he does whatever is required of him. And since he's a police officer, he does not have to do a lot of physical activity, but still anytime he tries to exert his knee, goes up and down stairs or does any long walking or standing, he has discomfort in his knee joint. Clinically, he's got a grade 3 Latchman. He's got a grade 2 pivot shift. He has an ACL tear on his MR scan. He's got a posterior third medial meniscus tear, which is a peripheral longitudinal tear, measures about 20 millimeters in length. But the reason to present this case is that he's got bilateral genu recurvatum. He's got knee hyperextension. His range of motion is -20, 0, 140, and he wants to stay active. So this is the case that is there. And before I ask any questions, does anybody want any more information so that I can share it there before I move on to the questions?
And the opposite side is normal, no symptoms on the opposite knee.
Opposite side does not have an ACL tear. He has a stable knee on the contralateral side, but bilaterally he's got hyperextension of -20, of about 20 degrees of hyperextension.
Are there other signs of hyperlaxity as well?
Correct. So he does not have hyperlaxity, but he has only genu recurvatum, which is why I use the word recurvatum for him. Yeah.
Sachin?
Yes?
Is he complaining of any pain, or is it only instability is his concern?
So he's got discomfort. He cannot do any activities when he wants to do them. So the moment he tries to, exert himself, he will get a minor effusion. He gets the odd buckling every 3 to 4 months, 5 months. So he has symptoms of instability and he's definitely not happy with his knee.
No, the reason I ask you about pain is if he has issues, the X-ray does not look so bad in terms of degenerative changes at all.
So we're not looking at any chondral lesions here. There's just a meniscus tear and there's a predominant ACL tear and an unstable knee.
Is the posterior slope increased on the tibia? Is that a weight-bearing lateral down?
Yes, it is. Okay, so everyone is happy. So the first question, I'll get Bhushan Sabnis to answer this. Why do you have recurvatum? What is the etiology of recurvatum, Bhushan?
Okay, so you stumped me once in PKC with this, so I don't know what you're talking about. Genu recurvatum can be either a genetic thing or that's because of the excessive slope on the tibia, which can lead to hyperextension. It can be due to hyperlaxity, or it can be due to chronic laxity, but this is unilateral. Is bilateral, then it's more likely to be genetic, or it can be due to alignment issues like excessive slope in the tibia.
So what is an excessive slope and how does an excessive slope lead to recurvatum?
So because of the excessive slope on the tibia, the posterior capsule is quite lax, and that leads to hyperextension in the knee joint. Now you got me stumped again.
No, absolutely perfect. Okay, so now once we've done this, of course, we are going to offer him surgery. So now going down the panel, Vikas Khanduja, are you still with us? I can't see Vikas anywhere.
He was on call, so
he'll be coming back.
Okay, Vikas Kapoor is there or he's also?
Yeah, I'm there.
Okay,
I'm
Vikas.
here.
So what is your choice of graft for this particular individual? Are you going to be using hamstrings, BTB, quad tendon with or without bone club, or are you going to be using an internal brace to protect your autograft?
Yes, I think this is one of the cases where I would preferentially use an internal brace with an autograft. And
what sort of autograft?
The hamstring grafts.
Hamstring. Clement?
Yeah, I would prefer hamstrings, but without internal brace. I don't want to make the knee stiff. We have to give them back the original recurvatum. Otherwise, you may end up with an unhappy patient. So I prefer a hamstring.
Are you not concerned that if you give them back hyperextension, they will re-tear their ACL one more time?
Yeah, I'll come to that. What I would do in these patients is we are facing an increased chance of failure after your reconstruction. Probably in these situations, I may also add an IT band tenodesis laterally to control the rotations. But I would go with the hamstrings in these patients.
Jacob, choice of graft.
I will use hamstrings, but I will fix it in full extension or even slightly hyperextension, because anyone who's got a recurvatum, I get them with an FFD, they don't like it. So I want them to get back.
No, we'll just talk about choice of graft, hamstrings.
Hamstrings.
Parag?
Yes, I would go with hamstrings for this case.
Raju?
Same here, hamstrings.
Kanchan?
BTB.
BTB. Dinshaw?
Hamstrings with internal brace, primarily because he's now 11 years post his injury. With a recurvatum, he's going to have some extensor tendinitis, some problems with his extensor apparatus for sure. So that's why I wouldn't touch the BTB.
Why do you think he would have problems with his extensor apparatus? I mean, his MR scan is showing that it's completely pristine. His cartilage, his tendons look fine.
So 41-year-old. So for me, a BTB is a good graft, but I think that you need to be really careful when you use that BTB. And one of the contraindications, at least for me, is patients who've had a chronic ACL deficient knee. They're certainly going to have some patellofemoral issues by that time. 10 years, 11 years down the line, especially if he's got a recurvatum, he's likely to have some issues there. So 41-year-old with hyperextension, that's the reason I wouldn't use a BTB.
You don't think of using the quad tendon?
I would use a
nothing from the extensor apparatus. So not the quad tendon and not the BTB.
Okay, Mukesh?
Hamstrings.
Hamstrings. And Bhushan?
Quad tendon.
With or without bone plug?
No, without. I don't use a bone plug normally.
Okay, so I think we've sort of run through the 9 panelists that we have, and there was one BTB, one quad tendon, and all the other were hamstrings. Okay, So where will you make your tibial tunnel? We'll start with Bhushan and then come down back again. Where will you put your tibial tunnel? Will you put it at the center of the ACL? Will you shift that insertion point posteriorly? Will you change it?
Now, in view of the hyperextension, the best thing is to actually see where your guide wire comes in when you're doing the tibial tunnel and hyperextending the knee. And if you can see if it's not impinging, that's quite good. But I think we'll need to push it slightly posteriorly in this case because of the hyperextension.
How much posterior will you push it?
So we'll go to the posterior margin of the ACL footprint rather than going just medial to the lateral anterior horn lateral meniscus. We'll go more posterior than that.
Mukesh?
Like the old way of doing transtibial ACL, little posterior, just posterior to the anterior horn of lateral meniscus, posterior border of the anterior horn.
Dinshaw?
Okay, so before I say that, I'll just give you my thoughts on this case, Sachin. So
okay.
The question is, why has this patient come to you after 11 years? He's come to you for that meniscus tear. So 11 years, he was doing well without his ACL. Now that he's landed up with the meniscus tear, that's where his discomfort comes from. My aim is to ensure that I repair that meniscus back.
Correct.
To have a good meniscus healing, I'm going to require an ACL reconstruction. So for that ACL reconstruction, now coming to your question, I take it like I would normally take an ACL reconstruction on the tibia. I'll take it right in the center. I won't put it too posterior, but at the same time, I want to be absolutely sure that when I take that guide wire, it's not impinging in extension. I certainly want him to get back his full extension. And because it's going to be a hamstring graft, I'm almost certain that he will slowly, even if he feels a little tight, if he's at say 3 or 4 degrees of hyperextension, over time, it's going to stretch out and come to his normal hyperextension. I think that will not be too much of a problem.
Okay, Raju?
Yeah, I would echo Dinshaw's thoughts in this regard. I would probably keep my graft right at the center with the same precautions that he mentioned, checking with the guide wire.
Parag?
Yeah, so I will see that the guide wire comes in the center, but I will, with the serial reaming, I always make the tibial tunnel serially. So I will go a little posteriorly as I dial in from 4, 6, 8, and a little bit posterior.
Clement, how about you?
Yeah, I would like to err on posterior than anterior.
Jacob?
I'll be central, but like I told you,
yeah,
normally I fix it in a different angle, that's all.
Okay. So Vikas, what angle will you tension the tibial side? So you've passed your you've passed your hamstrings graft, and what angle of knee flexion will you tension the tibial side now?
Okay, so am I audible?
Yes, you're audible. So you have to essentially tell us two things. At what angle of knee flexion are you going to tighten or you're going to fix the tibial end? And since you said that you're going to be using an internal brace, at what knee flexion angle are you going to be fixing your internal brace as well?
Yeah, so my knee flexion angle for tightening the ACL would be the same, which is for same as in like most of these which we do is at 90 degrees. We do the flexion, this thing flexion, and then we do the ACL tightening. And at 20-25 degrees between these two range of motion, depending on where we have put the graft. But internal brace, I would be tightening at around 10 degrees of flexion.
So if I can just rephrase your answer, you will tighten or you will fix the tibial side at 25 degrees of knee flexion, and you will fix your internal brace at 10 degrees of knee flexion.
Yes.
So are you not concerned that in someone who's got hyperextension, you will leave him with somewhat of a captured knee feeling afterwards?
I think he will overcome that. What 10 degrees we are discussing here is basically, I think it would land him in a erect knee situation over a period of time.
Yeah, I would tension the graft in 0 degree extension. If I'm using internal brace, I would tighten in the full recurvatum.
In full recurvatum.
Yeah.
Okay. Anyone have any different knee angle sort of preferences here amongst the panel?
Neutral,
0 degree
0 degree, or 1 or 2 degrees of flexion, in fact.
Flexion.
1 or 2 degrees. It will be 0 neutral, but I will not tension it in recurvatum.
Okay.
I'll agree with Jacob here and add a little bit of what Dinshaw said. Because I'm going to use BTB, the reason I'm going to use BTB is because this guy is going to stretch no matter what. And I'm going to tension it at 0 degree because I want him to get back his hyperextension. And the reason I'm using BTB is because I don't want him to stretch too much. But the fact remains that this guy's actually come here not for this ACL, but for the meniscus. That's the primary concern. We're going to handle the meniscus first and then make sure that his knee does not get unstable.
Okay, Bhushan, what degree of knee flexion do you want to fix your grafts?
Full extension. We don't want that graft to impinge. He has a higher risk of graft rupture again. He's a policeman, so hopefully he will be more active. So I would do it in full extension. Both, if I'm doing internal brace also, I'll fix it in the same position.
Who amongst the panel will add an extra-articular tenodesis?
I will do.
That was the point, sir. If under anesthesia, it's explosive pivot, because without anesthesia, it was grade 2. So we expect it to be grade 3 under anesthesia. So I would like to add LET.
Will you be doing an LET for the pivot or for protecting your graft? Because an LET can serve two functions. One is that it will serve a function for taking care of the so-called rotational laxity. Second function of your LET would be, or an extra-articular procedure would be, essentially to help or to protect your graft because this patient has got hyperextension. So
both purpose. In this case, both purpose.
will you do an ITB LET or would you do an ALL?
I'll do ITB LET.
Anyone who wants to do an ALL? Bhushan, you're the ALL man.
Yeah, so I would prefer to do an ALL rather than LET in this guy because of the hyperextension. And I'll fix the ALL in full extension again. So it will stretch out a bit, but it will still give some support to rotational issues. He's got grade 2 pivot in your clinical assessment. So it will be much more in your evaluation anesthesia. So I would do an ALL reconstruction.
So Bhushan, you want to use a robust graft like the quad tendon. You want to add an internal brace and you want to do an ALL.
Yes.
You want to do 3 things.
Yes, I do.
So you're the person who wants to take, triple protection, so as to say. Whereas all the others, couple of them, no pun intended. So question for you, Dinshaw, is now here we have 2 sort of extreme scenarios. One is someone who wants to use a robust graft like the quad tendon or the BTB, use an internal brace and add something on the lateral side. Whereas you would just like to do a standard hamstrings ACL. So can you defend your view here?
Yeah. With internal brace.
Yeah. With an internal brace.
Yeah.
Okay.
So
and what degree of, so before you answer that question, so what degree of knee flexion and for the tibial fixation and for the internal brace fixation?
Yeah, so I'm going to use a hamstring graft, 20 degrees of knee flexion for the graft, and I'll be putting the internal brace at 0 degrees to maybe even 5 degrees of hyperextension so that it doesn't become too tight. The reason being that I think that the hamstrings will slowly stretch out and it will allow him full hyperextension at the end of the day, that I'm sure. What Kanchan mentioned was absolutely right. So if it was a BTB, then certainly that graft would be fixed in full extension because otherwise you might capture the knee.
Can I say something, Dinshaw?
Yes.
Yeah. Now you said that you would put your needle in the middle of the ACL footprint when you do the reconstruction. So your graft diameter, if it is like 8, so 4 millimeter would be anterior to that and 4 millimeter posterior to that. And then you add an internal brace, which you would tighten in 5 degree or 10 degree hyperextension. Won't you put the impingement of the internal brace into the femoral condyle?
So Dinshaw, I'll just rephrase this question.
Yeah.
So let's answer it in two parts. When you are using an internal brace, do you have the tape in the center of the graft, or do you have it
Posterior.
anterior to the graft, or
No, it's
to the graft?
posterior.
One. And second is that you can then answer this question: differential tensioning of the brace and the graft, does it cause conflict?
Yeah, so basically I always put that internal brace posterior, and I always want to make sure that that internal brace is not going to cause any stress shielding of the graft. If I'm going to be fixing it at the same position, there's a high chance that it would actually cause stress shielding. It'll be stronger than the graft. The graft is not going to ligamentize and heal normally. So if I can put my graft in at 20 and make that nice and taut, and then put my internal brace in a position of full extension, then I think that it's basically going to be like a seat belt. It's going to be your secondary protector. It's not going to be tighter than the graft. It's not going to cause any impingement, and it's not going to cause any loss of extension.
Yeah, I thought you said hyperextension, internal bracing. That's what I thought.
Okay. I think, Sachin, the whole question here for me is, why is there a difference of such a vast difference of opinion? I think all of us agree that this patient is a high-risk patient.
Yes.
This patient with his hyperextension is a high-risk patient, and that's the whole reason why Bhushan would like to add an LET and others would like to add an LET. For me, the way I look at it is, this patient is 41, and he's come to you now 11 years after his ACL tear, which means that he was really managing without that ACL so well for 10 years. So do we really need to be too aggressive with his, with his knee? So that's the way I look at it. I think what would have been more challenging for me would be if the same gentleman came straight, 3 months or 4 months after his ACL injury, and you don't know how the natural history of that knee, how is it really gone? So in those scenarios, I think I treat this with an LET.
So let's say that, okay, instead of 11 years, he's come at 6 months.
Yes.
So,
So I think six.
amongst the panel, who wants to change their approach now? Yes, Dinshaw, what is your approach now? 6 months.
If he's at 6 months, then I think that he falls into my high risk for failure, and therefore I'm going to add an LET. But since he's coming at 11 years, I'm almost certain that he did so well without the ACL. I'm going to add an ACL that's only going to make him better. I'm going to make his meniscus heal. His discomfort's likely to go. He's likely to be more stable. And at the same time, I'm going to let him know that whatever activity modification you did over the last 10 or 11 years, please make sure that you continue with that. You don't get too aggressive with your knee, because you're a high-risk individual.
Yes, anybody else wants to change their plan if he comes at 6 months? Yes. Yeah. Clement, you want to say something?
Yeah. Even at this stage, Dinshaw, you've done your ACL reconstruction. Would you examine for pivot shift after you fix the graft? And what will you do if there is some residual pivot shift after you fix the graft? At 11 years.
This is you're talking of this scenario.
This scenario.
Okay,
You've done your ACLs only with hamstrings. Then you examine.
Yes. Yeah.
If there is a residual pivot, would you change your plan? Would you add an LET for this patient?
No, I wouldn't.
So I want to ask a question to the panel here. Amongst the panel, who makes a decision of doing a LET or a lateral sided procedure before they actually fix their ACL, and who decides that I will do it after I fix the ACL?
Before the ACL.
Should not be
so it's like, you go in the surgery with a plan that I'm going to do ACL with an extra-articular procedure, or you go and you go undecided every single time that I'm going to do an LET only if I see that there is a pivot post-surgery. Because almost always, once you fix your ACL, your pivot is going to drop. That is for sure. That's point number one. Second is that if you want to do an extra-articular procedure, you are better off fixing the femoral ACL first, then fixing your lateral extra-articular procedure, and then fixing the ACL tibia. That is what I follow in my clinical practice. So I think that if I have decided to do a LET, it is a pre-decided concept that this patient, after examination under anesthesia, requires an extraarticular tenodesis, and this is not something that I re-evaluate to do it again. Anybody disagree on that or agree on
No,
that?
I completely
in many
agree,
cases,
Dinsha. So my take is that it's a pre-op decision. Before the patient goes to the OR, I would take that decision. The only thing I differ is that what I do is once I do the ACL reconstruction, I fix on both the sides, and since I use a tightrope, what I do is after I do the lateral extraarticular tenodesis, I come back and then tighten the graft further since I use a tightrope on the femoral side. So that is my sequence of doing the surgery.
If you try and check pivot shift after your ACL graft is fixed, aren't you actually loosening the graft by doing that? And it's actually contraindicated to do any kind of rotational testing after you have done a fixation of your graft. That's what I
don't
I was about to come to that.
You
Actually,
are going to subject. No,
Yeah,
Bhushan,
it is very true, Bhushan. And not only pivot shift, there are biomechanical studies which show that even a Lachman done in the post-op period in the first 3 or 4 months, I mean, that strains the ACL by nearly 4%. Now, to give you a perspective, squatting with a 13 kilogram weight on top of your shoulder puts an ACL strain to around 1.2%.
Wonderful.
Sorry,
That's
come again?
Raju, that's different. That's a
different.
graft which is about 3 months old. So it's dead. But when you fix it, that's as strong as the graft, and you fix it. So I don't think there's any problem doing a pivot shift there. If it's slight, I
was involved in a study in Imperial College London where we fixed the graft on a cadaveric knee and did a Lachman test 5 times and retested the tension in the graft, and we found loosening despite your normal fixation options on femoral and tibial side. So there's about 5% loosening happening every time, and this was actually measured on a robotic test. So it's not something which can be taken lightly. I think we should be cycling and retensioning the graft at the end, but we should not be testing for pivot once you have fixed the graft both on femoral and tibial side.
I disagree, Bhushan. Bhushan is the strongest time. The strongest at 0.0, and many times it's a very good practice to gently evaluate, because sometimes the button would have flipped on a muzzle, or sometimes when you put the interference screws, you might have pushed the graft inside. There are few instances where we tested this residual laxity, then we realized the button was flipped on a soft tissue. And I don't think it's going to, because when you consider the amount of exercises you are subjecting the patient after 6 weeks, most of the open chain exercises are likely to put more stresses on the graft at 6 to 12 weeks than you're going to stretch the graft by doing a pivot at the end of your surgery.
Sachin, can I just make a point?
Yes.
I have a problem with your internal brace. I had a disaster in a patient who had a stiff knee. Someone did an MUA, and I found that the internal brace had torn when I scoped her. And then what happened is part of the ACL was stuck with the fat pad. When they've done the manipulation, it's like someone has taken a bite of the front of the ACL. So I have a problem with the internal brace. I don't know. Has anyone had an internal brace rupture?
No,
I never do it at all.
I personally don't use internal braces. So maybe the people who use internal brace, Vikas Kapoor, Dinshaw, and Bhushan could answer that question.
Well, in this particular situation is one of the situations where we would use it.
Is a problem. Are we lost?
But not on a day-to-day regular basis. Internal bracing is something which I'd be very careful about. And
So
it is this particular case
the question
which I'm
is that
suggesting
have you, Vikas, Dinshaw, and Bhushan, have you had problems of knee stiffness after the use of an internal brace along with an ACL autograft?
No, fortunately, no. Even at relook surgeries, also the brace, the tape is completely inert, and there is no synovial covering or reaction to it.
Your tape is anterior, posterior within the autograft?
Normally, it's within the graft.
Within the autograft.
Normally it's within the autograft. Yeah.
Dinshaw, have you had problems of stiffness?
No, not a single case that we've had any stiffness. But I think the way that you fix it is important. I think that I like it to be posterior to the graft, number one. In the center of the graft, I know a lot of people like it there, but I don't know whether that would come in the way of any ligamentization or the healing process. I don't know that, so I would rather avoid that. I don't want it anterior because of exactly what Vikas mentioned, that If you're putting it to full extension, is there a small amount of a laxity that comes in? Can it cause a small cyclops there with that irritation? We don't know. So I like to put it posterior, and I certainly want to make sure that it's not tighter, it's not causing any stress shielding. So therefore, my graft typically would be at 30 degrees, 20 to 30 degrees of flexion, and my internal brace would be tightened in full extension.
Dinshaw, if you feel that the internal brace doesn't cause stress shielding, isn't that defeating the very purpose why it was put? I mean, is it possible for an internal brace to not stress shield and yet protect the graft?
Yeah. So it's like your seat belt. You see that seat belt which holds you in a car, you've got, so only if you were to go beyond a particular level would that seat belt hold you back. So that's exactly what the internal brace is. So that internal brace is probably 1 or 2 millimeters less tight than the ACL. So in case there was a Lachman that someone did, or say the patient did have a twist, or there was some sort of increased anterior translation, that internal brace is going to act like a seat belt and prevent that internal, that excessive anterior translation, protect your graft. So I think that's the whole reason that we would put it into these high-risk patients.
So I think
patients like this, yeah.
Yeah. So if I can just summarize on this case, recurvatum is a high-risk group. There are different strategies to deal with it. Either you can use a robust graft like your BTB or the hamstring or the quad tendon. The other way is that if you want to use a hamstrings graft, which is likely to stretch, then you may choose to add an internal brace as an exceptional situation here. It is preferable to keep the internal brace posterior and not anterior. It is preferable to retension it in a slightly different angle so that it does not cause stress shielding. And you may choose to add a lateral extraarticular procedure to protect your graft. And the decision for this is preferably done pre-operatively, or rather before you start doing the ACL surgery, after doing a clinical evaluation under anesthesia. And you should preferably fix the lateral side first, complete it, and then fix the tibial end of the graft. So Parag, do we have time for one more case?
Yeah, we have time for one more case, but before we go, there are two questions.
Yes.
Two questions. One is by Dr. Mahajan from Karad. So he's asking, what exactly is internal bracing? What do you use? How is it done? A little more details of the internal brace.
So very quickly, I'll just discuss about internal brace. So internal brace is the use of a synthetic tape which is combined with your autograft. This tape essentially acts like a seat belt, as Dr. Dinshaw has said. This belt helps prevent or secure the graft from stretching out, especially while the graft is getting ligamentized and consolidated in the knee joint. And how to prepare it? There are various ways of preparing the graft. You can either have it separate to the graft as what Dr. Dinshaw prepares it, or you can have it incorporated within the graft, autograft in itself. And these are the two ways in which you can use it. Parag, any more questions?
One quick question.
Yes.
So like we have the scenario of ACL tear with the recurvatum.
Yes.
Dr. Sunny wants to ask that if there is a ACL tear with a flexion deformity.
Okay.
So what is the take of the panel? What do you do if there's a flexion deformity 10 degrees?
So you need to find out why there is a flexion deformity. The important reasons that come to my mind are in acute situations. If you have a flipped over stump, then it acts like a cyclops leading to a flexion contract or a deformity. That is pretty easy to treat. You just need to get rid of that flipped stump, and then your knee extends out completely. The second reason is in a chronic situation, if you have osteophytes in the intercondylar notch, or if you have an anvil osteophyte, then that will lead to a flexion contracture. In those scenarios, you need to get rid of those osteophytes, the anvil osteophyte, as well as the notch osteophytes. And the third is if you have a contracture in very chronic cases of the posterior capsule, wherein actually I would prefer to do it as a two-stage, in which I will go ahead and release the posterior capsule arthroscopically in stage 1, split the knee in full extension, and then come back. If I'm missing any more fourth cause, please feel free to add.
No, I think you've summarized it well, and given Dr. Sunny the answer he wants. Let's go.
Okay, I'll come to the last case now.
20 minutes.
Sachin, what do you do with this case? The third case, what do you do?
I'll come to it afterwards. Okay. So let's come to case 4. Now this is a 32-year-old male. he's got a high velocity motor vehicle accident. This is 3 days old, and as the x-rays show, this is a combined ACL MCL tear. The ACL has got grade 3 latchman, and the MCL is opening grade 3 in both full extension as well as 30 degrees of flexion. So when the MCL opens in full extension as well as 30 degrees of flexion, it tells us two things. One is that the ACL is completely torn. Second, it is an injury to the superficial MCL as well as the posterior oblique ligament, or the POL. So this is case 4, not an uncommon situation in our clinical practice, and this is being presented for management. The options being is that conserve the MCL and ACL today, don't do anything. He's 3 days down the track, come back after 3 weeks, put them in a cast or some sort of a fixed brace, then come back after 3, 4 weeks, 6 weeks, and then do both of them later. Option 2 is do a single stage MCL repair plus or minus augmentation and an ACL reconstruction today. Option 3 is wait for another week and do a single stage ACL MCL. And option 4 is do a stage 1 MCL today and then come back later after about say 3 months and do a stage 2 ACL. So Vikas Kapoor, will start with you very quickly. Option 1, 2, 3, or 4.
Sachin, we have Vikas Khanduja also back.
Okay, Vikas Khanduja, welcome back. So very quickly, if you can give your option, 1, 2, 3, or 4.
My option would be MCL repair plus augment today and second stage ACLR.
So option 4. Okay, Clement?
Yeah. Option 3.
Option 3. Wait for another week and do a single stage. Jacob?
I'll do option 3 because it's the tibial side avulsion.
Okay, that's good. Parag?
So option 2, I will repair and augment the MCL and ACL reconstruction day 1. As soon as when the patient comes to me.
Yeah, I will agree with Dr. Parag because it looks like a tibial sided avulsion, at least on the single MRI section that was seen.
Sachin?
2.
Option 2. Dinshaw?
Yeah, based on that MRI, I would do option 3. Do everything as a single stage because I think that MCL looks really good. It's going to be a primary repair. I don't think I'm going to need to augment it. And the knee doesn't look that inflamed and that acute based on the clinical evaluation. So it seems like I will be doing both at one shot. Just to be on the safe side, I'd give it a few more days. I won't do it on day 3. I'd like to do it at maybe between day 7 and day 10.
Mukesh?
I'll go with option 3 so that the surrounding edema and tissue subside and we have a good tissue to repair.
Bhushan?
I'll go between option 3 and 4. So I'll wait for 1 more week and then do a primary MCL repair plus augment it with SEMITI and then do a second stage ACL reconstruction.
So essentially you're doing option 4 after a week.
Yeah.
Correct? Okay, so here essentially what all of us have definitely agreed to do is that when we have grade 3 opening, none of us would like to conserve the MCL. And also for the very fact that if you see on the MR scan, this is a predominantly tibial sided injury, which is less likely to stick down and give rise to a good result. Of course, if you conserve this MCL and examine this patient, say after about 2 weeks or 3 weeks, the laxity of the MCL would have gone down, but definitely it will not be as normal as ever. So what boils down is for the panel to be split between doing a stage 1 or a stage 2 procedure. So I think Vikas Kapoor wanted to do a 2-stage procedure. Who wanted to do a 2-stage?
Yes, I wanted to do a 2-stage procedure.
So why do you want to do a 2-stage? Why do you want to lengthen this patient's recovery from a single stage to 2 stages, which will take him almost to about 6 months of recovery time? Why would you want to do that?
Yeah, for me, it is, I want to do this extra articular procedure now and give him a sufficient time for MCL to heal and get back the full range of motion, and then go ahead at maybe 3 months or 4 months time, whenever we have absolutely normal, good range of motion with good stability of the knee, varus valgus, and do the ACL reconstruction. That's it.
So,
Dr. Vikas, if I can add, is your concern a little bit regarding stiffness as well? Sometimes
Yes,
these
it is.
repaired
Yes,
MCLs
yes,
become stiff,
exactly.
and
And
they may
then
not need an ACL reconstruction at all.
they that is one. That is another way of looking at it, depending on whom I am operating. Now, if it is somebody in 40s and who doesn't need to be an athlete, maybe I'll get away with a bit of stiffness which remains. In the second stage, it would give me some time to understand how the knee is behaving, and then I would go ahead and fix the instability which is there for ACL.
but I think if you examine them on day one or whenever they come acutely to us, and you are convinced that this is a grade 3 ACL and a grade 3 MCL, why should we accept some laxity or some stiffness? Raju, you said that you could accept some stiffness. Why would that be so?
No, I mean, I was just trying to understand the thought process behind the stage. I mean, my choice would be either to repair them in a single stage. The MRI looked pretty bad. I do feel that augmentation might be required, but that would remain an intra-op decision.
Okay, so for all of those who are doing a single stage procedure, I'm going to ask you what will be the choice of graft for your ACL reconstruction. The choices are that you'll use ipsilateral hamstrings. Choice 2 is contralateral hamstrings. Choice 3 is ipsilateral BTB. Choice 4 is ipsilateral quad tendon. Bhushan, what is your choice? 1, 2, 3, or 4?
So
No, you
if
were a
I'm doing,
two-stage. You were a
yeah,
two-stage.
I'm
Sorry.
two-stage guy.
You're
Yeah.
out. You're out. Okay, Mukesh.
Contralateral hamstring.
Contralateral hamstrings. Dinshaw?
Ipsilateral BTB.
Ipsilateral BTB. Kanchan?
Ipsilateral BTB.
Raju?
I would do hamstrings if I don't need to augment the medial side, but if I'm augmenting, I'll do a quad tendon, ipsilateral, with a bone plug.
Are you worried that harvesting the hamstrings will compromise medial stability of your knee?
That's a theoretical concern, but I remember discussing this in detail at the PKC in the MCL meeting, the morning meeting that you did. And James Robinson was quite clear that hamstrings are grossly overrated as medial knee stabilizers. And in any case, if the MCL needs to be augmented, it's always better to use a semi-T. At least you're sparing one fixation at the tibial end.
Yeah, so that's the point that I wanted you to bring out. Parag, what's your choice?
So I'll use the contralateral semitendinosus and gracilis. If it is not so much thick, then the peroneus longus on the same side. I will prepare that also. Yes.
Okay. Jacob? Jacob, we've lost him. Okay, Clement?
I would use BTB ipsilateral.
So I think my preference is in such cases to use not touch the hamstrings, and I proceeded by doing a single stage procedure. So roughly around the 5th or the 6th day, in which the knee was repaired layer wise, starting from the tibial side. You start first repairing the meniscotibial ligaments, the deep MCL, the superficial MCL, and then later on he had a BTB ACL reconstruction. The advantage of doing a single stage procedure is that you grossly decrease the recovery time on all these patients. You help them recover faster, and by virtue of that, a lot of downtime is saved, and they can get back to their life very quickly. What is definitely essential is that you do require a very good physical therapist in your team, and you require a motivated patients, because when you do single stage surgeries, they definitely require a lot more effort for gaining back function, for gaining back strength, and for gaining back movement, which is completely essential. So choose your patient and choose your team is probably the message that I would like to give way here.